learning outcomes. After studying this module, you shall be able to learn the basic pathology and brain structures involved in intracranial tumors, IT, understand the different levels of severity of the IT, identify major causes involved in the IT, learn about various neurological and psychological symptoms of the IT, identify methods of diagnosis and treatment for the intracranial tumors. Introduction. A brain tumor known as intracranial tumor is an abnormal mass of tissue in which cells grow and multiply uncontrollably, seemingly unchecked by the mechanism that control normal cells. The two main groups of brain tumors are the primary and the metastatic. The primary brain tumors include tumors that originate from the tissues of the brain or the brain's immediate surroundings. Primary tumors are characterized as glial or benign and malignant. The benign tumors are not cancerous, whereas the malignant tumors involve abnormal growth and become cancerous. The glial or the benign tumors are composed of glial cells or non-glial developed on or in the structure of the brain, including nerves, blood vessels and the glands. And metastatic brain tumors, which include tumors that arise elsewhere in the body, such as the breast or lungs, and migrate to the brain, usually through the bloodstream. Metastatic tumors are considered cancerous. Metastatic tumors affect nearly 1 in 4 patients with cancer, or an estimated of 150,000 people a year. It has been estimated that up to 40% of people with lung cancer will develop metastatic brain tumors. The incidence of benign intracranial tumors has not been shown to vary significantly with nationality. However, studies examining the incidence of malignant central nervous system (CNS) tumors have shown some variation with national origin. Specifically, the incidence of CNS tumors in the United States, Israel and the Nordic countries is relatively high, while Japan and Asian countries have a lower incidence. These differences probably reflect some biological differences as well as differences in environmental factors. Some variation may also be due to pathologic diagnosis and reporting. Basic pathology of intracranial tumors. The picture below shows micrograph of an oligodendroglioma, a type of brain cancer. It was obtained by hematoxylin and eosinic staining of the biopsy of the brain. Tumors have characteristics that allow the determination of its malignancy and of how it will evolve and how the medical team will determine the management plan. Some of the processes that help describe the pathology of tumors are given below. 1. Anaplasia. Anaplasia or dedifferentiation is the loss of differentiation of cells and of the orientation to one another and blood vessels, a characteristic of anaplastic tumor tissue. Anaplastic cells have lost total control of their normal functioning and many have deteriorated cell structures. Anaplastic cells often have abnormally high nuclear to cytoplasmic ratios and many are multinucleated. Second, atypia. Atypia is an indication of abnormality of a cell which may be indicative of malignancy. Significance of this abnormality is highly dependent on the context. Third, neoplasia. It is uncontrolled division of cells. As such, neoplasia is not problematic, but its consequences are the uncontrolled division of cells. It means that the mass of neoplasm increases in size and in a confined space such as intracranial cavity. This quickly becomes problematic because the mass invades the space of the brain, pushing it aside, leading to compression of the brain tissue. It leads to increased intracranial pressure and destruction of brain parenchyma. Increased intracranial pressure, ICP, may be attributable to the direct mass effect of the tumor, increased blood volume or increased cerebrospinal fluid, CSF volume. It may in turn have secondary symptoms. Fourth, necrosis. It is the premature death of cells caused by external factors such as infection, toxins or trauma. Necrotic cells send the wrong chemical signals which prevent phagocytes from disposing of the dead cells, leading to a buildup of dead tissues, cell debris and toxins at or near the site of the necrotic cells. 5. Arterial and venous hypoxia. Arterial and venous hypoxia, or the deprivation of adequate oxygen supply to certain areas of the brain, occurs when a tumor makes use of nearby blood vessels for its supply of blood, and the neoplasm enters into competition for nutrients with the surrounding brain tissue. More generally, a neoplasm may cause release of metabolic end products, example, free radicals, altered electrolytes, neurotransmitters, and release and recruitment of cellular mediators, example, cytokines that disrupt normal parenchymal function. Anatomical structures involved in intracranial tumors. Meninges. Human brains are surrounded by a system of connective tissue membranes called meninges that separate the skull from the brain. This three-layered covering is composed of, from the outside in, the dura mater, that is the hard mother, arachnoid mater, which is spider mother, and pia mater, which is soft mother. The arachnoid and pia are physically connected and thus often considered as a single layer, the pia arachnoid. Below the arachnoids is the subarachnoid space, which contains cerebrospinal fluid, which circulates in the narrow spaces between cells and through cavities called ventricles, and serves to nourish, support, and protect the brain tissue. Blood vessels enter the central nervous system through the perivascular space above the pia mater. The cells in the blood vessels walls are joined tightly, forming the blood-brain barrier which protects the brain from toxins that might enter through the blood. Tumors of the meninges are meningioma and are often benign neoplasms. Brain matter. The brains of the vertebrates, including humans, are made of very soft tissue with a texture that has been compared to gelatin. Living brain tissue is pinkish on the outside and mostly white on the inside, with subtle variations in color. Three separate brain areas make up the majority of the brain volume. They are 1. Telencephalon, which includes the cerebral hemisphere or cerebellum. 2. Mesencephalon, which is the midbrain. And 3. Cerebellum. These areas are composed of two broad classes of cells, neurons and glia. These two types are equally numerous in the brain as a whole, although glial cells outnumber neurons roughly 4:1 in the cerebral cortex. Glia are of the several types which perform a number of critical functions including structural support, metabolic support, insulation, and guidance of development. Primary tumors of the glial cells are called glioma and often are malignant by the time they are diagnosed. Spinal cord and other tissues. The pink area in the above picture is the pons and is a specific region that consists of myelinated axons, much like spinal cord. The yellow region is the diencephalon, that is the thalamus and the hypothalamus, which consists also of neuron and glial cell tissues with the hypophysis or pituitary gland and the pineal gland, which is a granular tissue attached to the bottom. Tumors of the pituitary and the pineal gland are often benign neoplasms. The turquoise region or medulla oblongata is the end of the spinal cord and is composed mainly of neuron tissues enveloped in Schwann cells and meningeus tissue. Our spinal cord is made up of bundles of these axons, glial cells such as the Schwann cells in the periphery or within the cord itself. Oligodendrocytes wrap themselves around the axon, thus promoting faster transmission of electrical signals and also providing for general maintenance of the environment surrounding the cord, in part by shuttling different compounds around, responding to injury, etc. Levels of severity of intracranial tumors. The World Health Organization (WHO) has developed a grading system to indicate a tumor's malignancy or benignity based on its histological features under a microscope. Causes of intracranial tumors. Brain tumors are thought to arise when certain genes on the chromosomes of a cell are damaged and no longer function properly. These genes normally regulate the rate at which cell divides, if it divides at all, and repair genes that fix defects or other genes, as well as genes that should cause the cell to self-destruct if the damage is beyond repair. In some cases, an individual may be born with partial defects in one or more of these genes. Environmental factors may then lead to further damage. In other cases, the environmental injury to the genes may be the only cause. It is also known why some people in the environment develop brain tumors while others do not. Once a cell is dividing rapidly, an internal mechanism to check its growth and damage, the cell can eventually grow into a tumor. Another line of defense may be the body's immune system, which optimally would detect the abnormal cells and kill it. Tumors may produce substances that block the immune system from recognizing the abnormal tumor cells and eventually overpower all internal and external deterrents to its growth. A rapidly growing tumor may need more oxygen and nutrients than can be provided by the local blood supply intended for normal tissue. Tumors can produce substances called angiogenesis factors that promote the growth of blood vessels. The new vessels that grow increase the supply of nutrients to the tumor, and eventually the tumor becomes dependent on these new vessels. People who have had radiation to the head to diagnose or treat illnesses, including head CT scans, some types of dental x-rays, or radiotherapy for a previous brain tumor, may have an increased risk of brain and other central nervous system tumors, particularly if they received the radiation at a younger age. Current evidence shows that it is unlikely that use of mobile phone increases the risk of brain and other central nervous system disorders. Neurological and psychological symptoms of intracranial tumors. Symptoms vary depending on the location of the brain tumor, but following may accompany different types of brain tumors. Headaches that may be more severe in the morning, seizures or convulsions, difficult thinking, speaking or articulation, personality changes, weakness or paralysis in one part or one side of the body, loss of balance or dizziness, vision changes, hearing changes, facial numbness or tingling, nausea or vomiting, confusion and disorientation. Presenting signs and symptoms in patients with primary brain tumors: headache 56%, memory loss 35%, cognitive changes 34%, motor deficits 33%, language deficit 32%, seizures 32%, personality change 23%, visual problems 22%, changes in consciousness 16%, nausea or vomiting 13%, sensory deficit 13%, and papilledema 5%. Diagnosis of intracranial tumors. Sophisticated imaging techniques can pinpoint brain tumors. Diagnostic tools include computed tomography, CT or CAT scan, and magnetic resonance imaging, MRI. Intraoperative MRI also is used during surgery to guide tissue biopsies and tumor removal. Magnetic resource spectroscopy, MRS, is used to examine the tumor's chemical profile and determine the nature of the lesions seen on the MRI. Positron emission tomography, PET scan, can help detect recurring brain tumors. Sometimes the only way to make a definitive diagnosis of a brain tumor is through a biopsy. The neurosurgeon performs the biopsy and the pathologist makes the final diagnosis, determining whether the tumor appears benign or malignant and grading it accordingly. Treatment of intracranial tumors. Brain tumors, whether primary or metastatic, benign or malignant, usually are treated with surgery, radiation, and or chemotherapy, alone or in various combinations. While it is true that radiation and chemotherapy are used more often for malignant residual or recurrent tumors, decisions as to what treatment to use are made on a case-by-case basis and depend on a number of factors. There are risk and side effects associated with each type of therapy. Surgery. It is generally accepted that complete or nearly complete surgical removal of a brain tumor is beneficial for the patient. The neurosurgeon's challenge is to remove as much tumor as possible without injuring the brain tissue important to the patient's neurological functions such as the ability to speak, walk, etc. Traditionally, neurosurgeons open the skull through a craniotomy to ensure they can access the tumor and remove as much of it as possible. Another procedure that is commonly performed sometimes before craniotomy is called as stereotactic biopsy. This smaller operation allows doctors to obtain tissue in order to make an accurate diagnosis. Usually, a frame is attached to the patient's head, a scan is obtained, and then the patient is taken to the operating area where a small hole is drilled in the skull to allow access to the abnormal area. A small sample is obtained for examination under the microscope. In the early 1990s, computerized devices called surgical navigation systems were introduced. These systems assisted the neurosurgeon with guidance, localization, orientation for tumors. This information reduced the risk and improved the extent to which tumor removal could happen. In many cases, surgical navigation systems allowed previously inoperable tumors to be excised with acceptable risks. Some of these systems also can be used for biopsies without having to attach a frame to the skull. One limitation of these systems is that they utilize a scan, CT or MRI, obtained prior to the surgery to guide the neurosurgeon. Thus, they cannot account for movements of the brain that may occur intraoperatively. Investigators are developing techniques through ultrasound and performing surgery in MRI scanners to help update the navigation system data during surgery. Intraoperative language mapping is considered by some as a critically important technique for patients with tumors affecting language function such as large dominant hemisphere gliomas. This procedure, involving operating on the conscious patient and mapping the anatomy of the language function during the operation. The doctor then decides which portion of the tumor are safe to reset. Recent studies have determined that cortical language mapping may be used as a safe and efficient adjunct to optimize glioma resection while preserving essential language sites. Ventriculoperitoneal shunting may be required for some patients with brain tumors. Everyone has cerebrospinal fluid, CSF, within the brain and spine that is slowly circulating all the time. If this flow becomes blocked, the sacs that contain the fluid, the ventricles, can become enlarged, creating increased pressure within the head, resulting in a condition called hydrocephalus. If left untreated, hydrocephalus can cause brain damage and even death. The neurosurgeon may decide to use a shunt to divert the spinal fluid away from the brain and therefore reduce the pressure. The body cavity in which the cerebrospinal fluid is diverted usually is the peritoneal cavity, the area surrounding the abdominal organs. The shunt usually is permanent. If it becomes blocked, the symptoms are similar to that of original condition of hydrocephalus and may include headaches, vomiting, visual problems, and or confusion or lethargy among elders. Radiation therapy. Radiation therapy uses high energy X-rays to kill cancer cells and abnormal brain cells and to shrink tumors. Radiation therapy may be an option if the tumor cannot be treated effectively through surgery. Standard external beam radiotherapy uses a variety of radiation beams to create conformal coverage of the tumor while limiting the dose to surrounding normal structures. The risk of long-term radiation injury with modern delivery methods is very low. Newer techniques of delivery, aside from three-dimensional conformal radiotherapy, 3DCRT, include intensity modulated radiotherapy, IMRT. Proton beam treatment employs a specific type of radiation in which protons, a form of radioactivity, are directed specifically to the tumor. The advantage is that less tissue surrounding the tumor incurs damage. Stereotactic radiosurgery such as gamma knife, Novelis and cyber knife is a technique that focuses the radiation with many different beams on the target tissue. This treatment tends to incur less damage to tissue adjacent to the tumor. Currently, there is no data to suggest one delivery system is superior to another in terms of clinical outcomes, and each has its own advantages and disadvantages. Chemotherapy. Chemotherapy generally is considered to be effective for specific pediatric tumors, lymphomas, and some oligodendrogliomas, while it has been proven that chemotherapy improves overall survival in patients with the most malignant primary brain tumors. It does so in only about 20% of all patients, and physicians cannot readily predict which patient will benefit before treatment. As such, some physicians choose not to use chemotherapy because of the potential side effects: lung scarring, suppression of the immune system, nausea, etc. Chemotherapy works by inflicting cell damage that is better repaired by normal tissue than tumor tissue. Resistance to chemotherapy might involve survival of tumor tissue that cannot respond to drug, or the inability of the drug to pass from the bloodstream into the brain. A special barrier exists between the bloodstream and the brain tissue called the blood-brain barrier. Some investigators have tried to improve the effect of chemotherapy by disrupting this barrier or by injecting the drug into the tumor or brain. The goal of another class of drugs is not to kill the tumor cells, but rather to block further tumor growth. In some cases, growth modifiers such as breast cancer treatment, drug tamoxifen have been used to attempt to stop the growth of tumors resistant to other treatments. In 1996, the US Food and Drug Administration approved the use of chemotherapy impregnated wafers, which can be applied by the neurosurgeon at the time of surgery. The wafers slowly secrete the drug into the tumors, and the patient receives chemotherapy with the systemic side effects of treatment. Investigational therapies. Many types of new therapies currently are being studied, especially on tumors for which the prognosis is generally poor through existing conventional therapies. It is unknown whether these therapies will work. Such therapies are given according to a protocol and include various forms of immunotherapy. It is the therapy using targeted toxins, anti-angiogenesis therapy, gene therapy, and differentiation therapy. Combinations of treatments may also be able to improve the outlook for patients while lowering the adverse side effects. Summary. Brain and intracranial tumors are abnormal mass of tissue that multiplies uncontrollably. They may be primary or metastatic. Primary tumors develop in the brain itself, whereas the metastatic tumors develop elsewhere in the body and migrate to the brain. Pathological processes involved in the development of tumors are anaplasia, atypia, neoplasia, necrosis, and hypoxia. World Health Organization has developed a system to classify them into high and low grade tumors as per their severity. The major symptoms are seizures, visual and auditory difficulties, numbness of limbs, loss of balance, confusion, disorientation, and personality change. The major causes are genetic, environmental, radiation, and repeated exposure to X-rays. They can be treated with surgeries, radiotherapy, chemotherapy, proton beam therapy, and stereotactic radiosurgery. The prognosis is very poor.